Your doctor means well, but meaning well and doing right by you are not always the same thing. And for 5 of the most common tests ordered in adults over 60, the evidence says the test itself is the problem, not the disease. The test. This isn't fringe medicine. This isn't contrarianism for the sake of it. The recommendations against these tests come from the U.S. Preventive Services Task Force, the same body that sets the screening guidelines your doctor follows. Multiple major medical associations have backed them up. The Choosing Wisely campaign, backed by dozens of medical specialty societies, has specifically flagged these as procedures that are routinely ordered on older adults when they shouldn't be, and yet they keep happening. At annual checkups, billed to Medicare, presented as standard care. The reason this matters isn't abstract. When a test finds something, even something real, in an older adult who was never going to be harmed by it, a clock starts, a referral gets made, another test gets ordered, a biopsy, a procedure, and somewhere in that chain, the patient who walked in healthy walks out with a complication they'll spend months recovering from for a condition that was never going to touch them. That's not a hypothetical, that's a documented pattern, and it has a name: overdiagnosis. Understanding which tests fall into this category, and more importantly, what to say to your doctor when they're ordered, is one of the most useful things you can do for your health after 60. So let's get into it. Start with a question most people have never been asked. When your doctor orders a test, what's the actual plan if it comes back positive? Not in theory. Specifically, what happens next? And what does that chain of events cost you? Because here's what the medical system doesn't communicate clearly enough. Every test has 2 sets of consequences. What happens if it finds something dangerous, and what happens if it finds something that isn't. The second category is where older adults consistently get hurt. There's a concept called the false positive rate. It's the percentage of time a test lights up when nothing is actually wrong. And in older bodies, false positive rates go up, because older bodies have more variations, more incidental findings, more things that look unusual on a scan or in blood work, but are completely benign. They're the medical equivalent of background noise. But once a test picks them up, the system treats them like a signal, and then the cascade begins. A positive result triggers a follow-up test, which triggers a referral, which leads often enough to a biopsy or a procedure. And that procedure has its own complication rate. In people over 70, those rates are meaningfully higher than in younger patients. Not catastrophically higher, but higher, enough to matter. The thing about overdiagnosis that most people don't grasp until it happens to them is this: the doctor didn't make an error. The test found something real. The biopsy confirmed it. The diagnosis is technically correct. But the cancer, or the abnormality, or the shadow on the scan was never going to cause a problem. It was going to sit there silent until the person died of something else entirely at 84. Instead, they're now 3 weeks post-surgery, managing a complication and wondering what happened. That pattern is not rare. Australian researchers found that 1 in 5 common cancers is detected through overdiagnosis. 1 in 5. The age factor matters here more than most people realize. A cancer that takes 15 years to become dangerous is not the same risk at 72 as it is at 52. Time is the variable that changes everything. The tests were often designed and validated in younger populations where the math is different, where you have more years ahead to benefit from catching something early. After 60, and especially after 70, that calculation shifts. The benefit window shrinks. The harm window stays the same. That's the framework. Keep it in mind as we go through each test, because it's the reason the same screening that saves a 55-year-old's life can genuinely hurt a 75-year-old. The PSA test, prostate-specific antigen. If you're a man over 60 and you've had an annual physical in the last decade, there's a reasonable chance this was on your blood work, possibly without a detailed conversation about whether it should be. The U.S. Preventive Services Task Force issues a formal D recommendation against PSA screening in men 70 and older. D is their strongest level of recommendation against a service. The language they use is specific. The potential benefits do not outweigh the expected harms, not the evidence is unclear, not use your judgment. The harms outweigh the benefits. Why? Two reasons that compound each other. First, the false positive rate. In men over 70, nearly half of positive PSA results are not cancer. Nearly half. So you get a call from your doctor's office, your stomach drops, and there's roughly a coin flip chance that what they found isn't what they think it is. But the biopsy still happens. Second, and this is the part that changes the conversation entirely, 1 in 3 men aged 70 to 79 already has prostate cancer cells in his prostate. 1 in 3, discovered at autopsy in men who died of completely unrelated causes, who never had a single symptom. That cancer was never going to move. It was never going to spread. It was going to stay exactly where it was for the rest of their lives. Routine PSA testing finds those cancers too, and then treatment happens. Among men who have prostate cancer surgery, 14% lose bladder control permanently. Another 14% develop erectile dysfunction. That's 1 in 7 men treated for a cancer that, in many cases at this age, would never have touched them, now managing a life-altering side effect. I want to tell you about a patient I saw some years ago. He came in for a routine physical at 74, active man, walked every morning, took his grandkids fishing on weekends, no symptoms of anything. His PSA came back elevated. We followed the cascade. Biopsy confirmed a low-grade cancer. His urologist recommended treatment, and he chose surgery. Standard of care, every step of it done correctly. 8 months later, he came back to see me. He wasn't walking in the mornings anymore. The incontinence had made it too unpredictable. He'd stopped taking his grandkids fishing because he didn't trust his body around people he loved. He said, and I remember this clearly, I felt fine before I knew. I haven't felt fine since. The cancer almost certainly wasn't going to kill him. The treatment changed how he lived every day that he had left. That is what overdiagnosis costs, not a number, a morning walk, a Saturday on the water. That's why the USPSTF recommendation exists. Colonoscopy after 75 works differently. And I want to be precise here, because colonoscopy is a genuinely life-saving procedure for the right patient at the right time. This isn't about eliminating it. It's about understanding when the calculus changes. The USPSTF recommends routine colonoscopy screening up to age 75 for average-risk adults. After 75, the guidance shifts to individual decision-making. After 85, it recommends against screening entirely. The reason is straightforward. Colorectal cancer typically takes 10 or more years to develop from a polyp into something dangerous. If you're 80 and a colonoscopy finds a very early polyp, the math on whether you'll ever actually be harmed by it changes considerably. What doesn't change is the complication rate. In adults 65 and older, colonoscopy causes serious adverse events: perforation of the colon, bleeding, cardiovascular stress from the sedation, at a rate of nearly 26 per 1,000 procedures. In adults over 80, that rate climbs to nearly 35 per 1,000. The bowel prep itself causes dehydration and dangerous electrolyte shifts in older adults, particularly those with kidney or heart conditions. More than half of older adults who are outside the recommended window are still getting these procedures. In one analysis, 71% of patients aged 81 to 85 with a limited life expectancy had a colonoscopy. The cancer it might have found was extremely unlikely to have affected their health. The procedure's complications were not. If your doctor recommends a colonoscopy and you're over 75, the right question is simple. Given my overall health and how long I'm expected to benefit from finding something, does this make sense for me specifically? That is a conversation worth having before you schedule the prep. The routine cardiac stress test, EKG treadmill test. You've probably had one or know someone who has, ordered as part of an annual checkup with no specific symptoms and no particular reason other than let's just take a look. The U.S. Preventive Services Task Force recommends against this for asymptomatic adults at low cardiac risk. So does the American College of Cardiology, the American Heart Association, the American College of Physicians, the Choosing Wisely campaign. This is one of those rare cases where virtually every major medical body is saying the same thing, and yet the test is still extremely common. Pay attention to this next part, because it illustrates the cascade perfectly. A routine stress test in a low-risk patient has a high false positive rate. The heart does something during exertion that looks unusual on the monitor. It may be completely benign, a normal variation in an older heart, but the test flags it. Now there's a finding. The finding needs follow-up. So, a referral goes to a cardiologist. The cardiologist orders further imaging. In some cases, that leads to cardiac catheterization, a procedure where a thin tube is threaded through your arteries to image the heart directly. Up to 3% of people who get a stress test end up referred for that catheterization. And here's the part that should stop you cold. 1.7% of those catheterizations cause severe adverse reactions in people who turn out not to have heart disease at all, people who had no symptoms, who went in for a routine checkup, who are now recovering from a serious complication of a procedure that was triggered by a test that wasn't recommended for them in the first place. The research is also clear that cardiac stress tests in asymptomatic low-risk people don't actually change outcomes. They don't reduce heart attacks. They don't extend life. They find things, and then they set a chain of events in motion that can cause real harm without providing the benefit that justifies the risk. If you have symptoms, chest pain, shortness of breath, palpitations, this is a completely different conversation. Those warrant evaluation. The problem is the routine, symptom-free, while you're here version that gets ordered because it feels thorough. Thorough is not the same as helpful. That distinction is worth holding on to. The fourth test tends to genuinely surprise people. Thyroid cancer screening in asymptomatic adults. The USPSTF issues a D recommendation against this too, but the reason why is the most striking thing in this entire video, and I want you to really hear it. Over the past decade or so, the rate at which thyroid cancer is being detected in the United States has increased by 4.5% every single year. That sounds alarming, like there's an epidemic, except the death rate from thyroid cancer hasn't moved, not up, not down. It has stayed flat at 0.5 deaths per 100,000 the entire time detection was climbing. Think about what that means. We're finding vastly more thyroid cancer. We're treating vastly more thyroid cancer, and no fewer people are dying from it. What's happening is that better imaging, ultrasounds ordered for unrelated reasons, incidental findings on neck exams, is picking up tiny thyroid nodules that would have sat there forever. Autopsy studies confirm this. 11.5% of thyroid glands examined at autopsy contain papillary thyroid cancer. People who died of completely unrelated causes, who never knew it was there, who were never harmed by it. The treatment for thyroid cancer is surgery, full or partial removal of the thyroid gland, followed in many cases by radioactive iodine therapy and a lifetime of thyroid hormone replacement medication. That is not a small intervention. That is a permanent, life-altering course of treatment for a cancer that in most of these cases was never going to cause a single symptom. Screening for thyroid cancer, routine neck ultrasounds, palpation checks in people without symptoms is how these cancers get found. And the USPSTF has concluded with moderate certainty that the harms outweigh the benefits. Not because thyroid cancer isn't real, it is, but because the version most often found through screening is the version that was never going to hurt anyone. The fifth test is the most delicate one to talk about because mammography is genuinely one of the most effective cancer screening tools we have For the right person at the right age, it saves lives. That's not in question. What is in question is whether it should continue indefinitely. And for a specific group of older women, the evidence says it shouldn't. The American Cancer Society recommends mammography only in patients expected to live 10 or more years. That's not a cutoff based on age alone. It's based on time horizon. Screening works by catching cancer early enough that treatment has time to make a difference. If someone's life expectancy, due to age or other serious health conditions, is less than 10 years, the cancer that a mammogram might find today is unlikely to affect their quality or length of life. The screening benefit, the early catch, the time advantage, doesn't materialize. But the harms of screening do. And those harms are real. A false positive means a callback. The callback leads to a biopsy. In older women, particularly those with cognitive decline or other serious health conditions, that entire chain carries real costs: the anxiety, the procedures, the follow-up burden, in exchange for a benefit the math can no longer deliver. Research published in the American Journal of Public Health found that nearly 1 in 5 women with severe cognitive impairment are still receiving routine mammograms, even though they fall clearly outside the window where screening guidelines recommend it. These are women for whom the procedure offers no plausible benefit and carries a real potential for distress and harm. The same pattern runs through all 5 of these tests. The test itself isn't wrong, the timing is. A mammogram at 52 with no significant health conditions makes complete sense. The same mammogram ordered automatically at 82 in a woman with advanced dementia who would never tolerate treatment if something were found. That's a different calculation entirely, and it should be treated as one. So, where does this leave you? Not frightened, I hope. That's not the point of this. The point is that you are allowed, you are entitled, to ask questions before you agree to a test. And there are 3 specific questions that change every conversation with your doctor. The first, what happens if this comes back positive? Walk me through the next steps, not the best case scenario, the realistic one. The second, given my age and my overall health, is the benefit of finding something early greater than the risk of the cascade that follows? The third, and this one matters most, if we found something with this test, would we actually treat it, or would monitoring be the more appropriate path? Those 3 questions reframe the entire appointment. They move you from a passive recipient of standard care to an active participant in a decision that affects your body and your life. That is what informed consent actually looks like in practice. Your doctor isn't your adversary. Most are doing exactly what their training and the system around them have shaped them to do. But that system was not always designed with the specific realities of aging in mind, and you're the one who has to live with the results of the decisions made inside it. Know which tests are on this list. Ask the questions, and if the answers don't satisfy you, ask again. That's it. Subscribe if you haven't. There's more on navigating the medical system after 60 coming, and I think you'll want it. Take care of yourself.